Hello, everybody. We are so excited to be with you once again, Tuesdays at noon. And we thank you for joining us. It's Good Health by Claudia podcast with me, Denny Schaefer. Claudia, of course, the star. And it's a production of Denny Radio. We're at episode 120. 120. And today we are going to talk about thermography. Thermography.
Such an important subject.
And we have an expert. Can we say that? He's an expert?
He's definitely an expert.
Dr.
Yes.
Hoekstra.
Yep.
Dr. Phil Hoekstra.
Yep.
A board-certified clinical thermologist and senior medical scientist recognized for his extensive work in alternative and adjunctive breast cancer screening through medical infrared imaging thermography.
Yes.
Wow.
Yeah.
This guy's a big deal.
Oh, he's wonderful.
And you know him?
I do. I've been very blessed to know him.
You know so many people.
Well, I've been in the industry a long time.
How old are you?
68.
68?
That's a good age, huh?
It is. You look good.
Well,
you have awesome skin, by the way.
Thank you.
Okay. Are we ready to bring in Dr. Phil?
Yes, we are ready.
There's our guest, ladies and gentlemen. Say hello to Dr. Phil Hoekstra. Hello, doctor. Can you hear us?
I can hear you just fine. A pleasant good day.
There he is.
Can we hear him?
Nice to have you.
Thank you very much.
Oh, there he is.
Okay.
Yes.
Where do you want to start, Claudia?
Well, so Denny, did you hear what Denny, the introduction?
I did.
And you're happy with that? Because we
It'll do. I could always say that I was born a poor black child, but that would be the wrong movie.
I love that movie. What was that? The Jerk?
Yeah.
Yes.
Jerk?
Yes.
With Steve Martin.
Yeah.
Yes, exactly.
I like it. We like the same movies.
So yes, you've had many, many years on this journey of learning and sharing and teaching about thermography and this very important way of addressing women's health. So can you tell us where it all started for you?
Where it started for me was on my father's knee. He was a real pioneer in the field, developing the cameras back in the late 50s and early 60s. Our family basement became one of those undisclosed secured location where he was able to do a lot of development and testing of cameras that were a one-off that would end up being the prototypes for cameras that would end up in satellites. He was a project director for any number of satellite programs, including some of the ones that went to military intelligence applications as well as weather surveillance. For me, having an optical lab in the basement seemed to be one of the most natural things in the world. He did, as I say, pioneering work in terms of the equipment on it, but he saw an opportunity for this in medicine as he hobnobbed, cohorted, and otherwise hung out with some of the real pioneers in that. Together in 1972, we started Thermoscan as the first freestanding facility doing diagnostic infrared work in the world. It was built in the worst business model you can imagine. If you build it, they will come. But it was very clear even then that there was a major need to reform what was taking place in terms of screening for breast disease. And the literature on that type of thing at the time was already very convincing, and it's become more so since then. I was, where is it? I have a brochure here from the American Cancer Society from that era that indicated that thermography in its present form back in the late 60s was already beyond the experimental stage. The Food and Drug Administration had approved thermography in its early forms as being beyond experimental, and it had equal status with mammography in that era. What was appealing as I matured in my work in medicine is to do non-invasive types of tests. Certainly, it's very clear that breast cancer has a multifactorial origin, and certainly one of them, one of the most well-developed ones, is ionizing radiation, and to be able to test for and pick up the earliest signs of breast disease non-invasively without irradiating a woman's breast had a great deal of appeal. It didn't take long to discover that we were finding breast cancers at much earlier stages than were being found otherwise. It's a very reinforcing thing to know that there's people who are alive today because of the work that you're doing.
Yes.
And what's especially appealing is having done so much of the developmental work by our group. We've done just about every important work in development in terms of the equipment, in terms of diagnostic standards. I had the opportunity to do fellowships at 4 different national sites of major repute. I dare say we're doing the very best work that's taking place on the planet.
I absolutely agree with that. And I'm so grateful you're with us. You and I met, I don't know, 25 years ago or something. And,
we both had darker hair then.
Yes, we did. But, I know that the women, after learning about thermography from you and Dr. Chappell, I've talked about Dr. Chappell many times. God bless him, he's no longer living, but he was a wonderful man and very much ahead of his time, like Dr. Hoekstra. I'm so grateful because over the years I've sent, I don't know, hundreds of women for thermography, and I feel very good about that. You had touched on the issue of radiation, and I just want to clarify that is not this technology.
No. Thermology, I'm going to use the term thermology because I believe that we understand this well enough and have developed it far enough to where it is a proper science. And unlike thermography, which is a little bit like thermal photography, we're approaching this from very much from a scientific analytic standpoint. And by that, I mean, when we get an image, we don't put it at arm's length, squint really hard, scratch a favorite body part and come to an opinion. But we have instead a defined analytic methodology for our work, and it's repeatable, and we have statistical feedback on its efficacy. But as you were saying, thermal imaging is completely passive. It's imaging the natural emissions of infrared energy from the body, and as long as a person is alive, they have temperature and they're emitting infrared energy. When they assume room temperature, they're really not of much interest to us any longer. But we look at the patterns and the emissions and the behavior of those heat patterns in a diagnostic sense. And one of the big applications here is for breast disease. And to me, it's still amazing that in some corners this is controversial. There are an abundance of facts and statistics and studies that have validated it. It is something that has been recognized since the early 1970s by the Food and Drug Administration as a authorized means of screening for breast disease. We use it for screening. We also use it diagnostically. The National Cancer Institute lists thermography as the earliest means of detecting breast disease in their website.
Yeah,
So,
love that.
Wait a minute. Wait.
Yeah.
So they even acknowledge
Right.
that early detection is more likely through thermography.
Yes.
So why isn't thermography the only way people go when they get tested for breast cancer, doctor?
Well, let's go back in a little bit of history. It used to be that radiology, the medical discipline of X-rays, was kind of a backwater profession. You got the bad parking places, and the only time that you were busy and you had to live in basements of hospitals. But the only time you were busy was on cold and slippery nights when there would be a lot of traffic accidents and broken bones. And there was an obscure French technique involved X-raying the breast, and the goal was to improve upon the first pickup of the cancer. Now, prior to the establishment of mammography back in the 1970s, the standard of care for detecting breast cancer was a surgeon's fingers. And the surgeon would feel for something that was harder than what they would expect for a breast gland. They would feel for something that was more fixed than mobile, that would be typical for a fibrocyst. They would feel for something that was rough. And once again, they would squint real hard, scratch a favorite body part, and come to an opinion. And they would say, yes, I think I want this in a plate. And women would have excisional biopsies, and the vast majority of the time they were benign fibrocysts. There were women who had extensive fibrocystic disease, which was not as common then as it is now, whose breasts would begin to look like moonscapes from all the incisional biopsies that they had.
Yes.
So basically, there were every woman's impression that mammography was developed by two men. Yes, it was Jacob Kirschen-Cohen and Phil Strax did a project funded by the insurance plan in Greater New York back in the late 60s, where they demonstrated that by X-raying the breast using this obscure French technique, they could find the cancer at an earlier stage than was being found by the surgeon's fingers. So they demonstrated this, and they conducted, a very large-scale study was conducted at 27 different centers through the country that basically validated, yes, with mammography, they could find breast cancer at an earlier stage than what it was being felt by surgeons. Now, when a surgeon is poking around, the proper term is palpation on a woman's breast, the threshold as to what most women can find, irrespective of their breast size, is about the size of the tip of my finger, which is about an inch. A surgeon who does this type of thing day in and day out is a little better at it than most women, and the tip of my other finger here is about their threshold. Something has to be big enough to be able to be seen on an X-ray. But with urology, there is no type of a size threshold on that, because we're not looking at a physical structure.
Right.
We're looking at metabolic changes and blood vessel changes that take place actually before there can be any type of tumor discernible on an X-ray. And studies have shown 5 to 8 years before it is being seen on an X-ray, we've got positive thermology results.
Wow.
That's fascinating.
It is fascinating. It's amazing.
But getting back to my point, mammography basically transformed the whole radiologic profession. For quite a while, the radiologist became the best paying specialist in all of medicine. The American College of Radiology did a spectacular job of quality control and training to get mammography to a high level of development. But one of the truisms of mammography is that it's about as developed as it can be. Mammography was not the beginning and end all of means of testing for breast cancer.
Right.
It was taking an old technique around a burgeoning problem. Well, the problem hasn't gotten any better. And what's been clearly demonstrated is that the screening mammography programs are completely ineffective. At some point, it becomes clear that the emperor is not wearing clothes. And the illusion that many physicians have, and certainly most women have, is that when you get a mammogram, you've done all that's necessary, and if it comes back clear, you smile because everything is good. Come back again next year. Mm-hmm. And I can't tell you how many times there's a whole category called interval cancers, which means the breast cancer has been found between the time of the last screening in a year because it was basically missed. The overall sensitivity of mammography has become very poor as things have changed for women. We are not the same people that we were 50 and 100 years ago. Mm-hmm. And the incidence of breast cancer is going up. It's going up particularly among younger women. And mammography is particularly ineffective for younger women. If you have dense breasts, if you have fibrocystic disease, if you've had previous biopsies, if you've had implants or reductions, if you're pregnant or nursing, if you're built big or you're built small, the effectiveness of mammography is substantially reduced from any type of impression to the point to where it's not as good as a coin toss. There's a lot of women for whom breast cancer is being missed, and almost as bad are the women for whom breast cancer is being overdiagnosed. And as for many years, I've been watching the articles come through, especially about this time of year, in anticipation of the fall, which is Breast Cancer Awareness Month. Right. I think it was Mark Twain who had the quote, "There are three modes of lying. There are lies, damn lies, and statistics." And I've seen statistics torqued around beyond anything reasonable to try to make mammography and the effectiveness of the whole paradigm look much more effective than what it is. I
have questions.
Go ahead.
What's more accurate, thermography or a mammogram?
Yeah, it's a difficult question to answer because there are some breast cancers that are never seen on mammography that are basically a house on fire for us with thermal imaging. Mm-hmm. And vice versa. There are those that never show up on thermology that are very apparent on a mammogram. Now, that said, there's no such thing as a standard off-the-shelf one-size-fits-all breast cancer. Every breast cancer is defined by the specific mutations that have gone in terms of making it a cancer. And basically, there are some cancers that are so slow growing and will have dormant periods to the point that they will never bother a woman. They'll never be a palpable mass. They will represent no risk for that woman through her entire lifetime if she lives to 120. Now, those we tend not to see. The very slow, or what are called indolent breast cancers. But the ones that really need treatment are the ones that show up like a house on fire for thermology. And it's the opposite situation exists for mammography. For the slow-growing ones, the indolent ones, the ones that would tend not to be a problem are the ones that would tend to show up very well on mammography. The really aggressive ones that need immediate treatment to save somebody's life are the ones that they may miss. One of the key features you look for with mammography are clusters of irregularly faceted calcifications, and they tend not to grow at all like that in the very aggressive breast cancers. So I'm sorry I didn't give you a direct answer to that one, but it's the most truthful one I can think of.
So who decides mammogram over thermology? The patient?
Well, the good thing is that in this world, it does not have to be an either or. Now, for some women, okay, let me back up. Women really need to start screening before the time that mammography would be effective. Our youngest confirmed cases of breast cancer were in 14-year-olds, and that's exceptionally rare. It's a horrific situation. But we're seeing so many women these days being diagnosed into their 30s and 40s and 50s when mammography is not effective. So a practitioner looks at the tools that are available. Mammography is certainly one. I would never say that it's ineffective, but it's not in general, but it's not effective for younger women. But thermal imaging is. So to screen younger women for who are either at particular risk or have symptoms, or just because, we should be screening women certainly into their 40s and 50s. Now, for many women, mammography is an option, usually postmenopausal. And it's a dandy combination to combine thermal imaging with mammography. There you're studying a woman both anatomically with a mammogram as well as physiologically with thermology. And you've really got the best of all worlds at that point. So it's really not an either or choice for older women, but for younger women who really need to be screened, thermology should be the first thing that they look at.
But I think it's fair to say a lot of women that have had mammograms, because they can be painful, there's so much pressure on the tissue, and they're releasing low levels of radiation into the tissue, and that accumulates over the years, correct?
Oh, very much so.
So I think it's fair to say there's more women that are very interested in doing thermography because they don't want to go through the stress and the pain of a mammogram. And especially, I mean, we've had women that have had one a year every year, and you know they're so stressed out, they're getting sick from thinking about going for the mammogram. So I think all this is very important and needs to be a factor in the way in what women are choosing. But I just know that of all the years that we've been educating and sending people to Dr. Chappell, and they work with you directly, you know, women are thrilled to understand that they have an option. And I think it's a very important option. So.
Oh, I think so too. Otherwise I wouldn't be here doing this for this
Exactly.
long. I'm just hitting my 54th year in the field. That's not quite starting at the on my father's knee, but we did found Thermoscan in 1972, and you bring up a very important point in that women do need to be educated about this because if you're waiting for the prevailing paradigm to save your life, you may be waiting too long.
Right. And we recently had a woman that came to us. She did a mammogram. She was diagnosed as stage 1, and they right away were scheduling her for chemo and radiation. And her husband came in with her. They were so upset, and rightfully so.
Yeah. I'm
like, well, first of all, go get a thermogram, but here's all the things that you can do to help yourself.
Sure.
So, you know, I told you when we were talking or whatever it was, when I sent you an email, you know, I first learned about xenoestrogens and their impact on breast cancer way back when Dr. John Lee wrote his book.
Right.
And did you know Dr. John Lee? Did you know him?
I met him a few times, and I've certainly read his material.
Yes. And so when you say that women should be screened younger and younger, it's very sad, because I personally think a lot of why that is the environmental toxins that we're being impacted with. And I think it's interesting that for many years, in fact, I think they still check for estrogen positive receptor sites, right?
Of course, yes.
And so that to me is the impact of petrotoxins, which create xenoestrogens, which are man-made estrogen, and we're all uptaking them. So,
well, it's any variety of things. I mean, the plasticizers are known as carcinogens. We mentioned ionizing radiation is a known estrogen. A lot of the drugs that people are taking routinely are known carcinogens,
right.
and specific for breast cancer. So it really is a multifactorial disease. One of the clear things is, though, that the prevailing types of medical treatments and the foods that people are taking in and the environment in which we're living are all extremely conducive to breast cancer.
Yes.
What's really interesting is if you look at third world countries that don't have this type of thing, where people had been eating in traditional ways, their incidence of breast cancer is a small fraction of ours. And as living features change there to become more like what we have, you see the bloom in the incidence of breast cancer. For instance, there was a outbreak of inflammatory carcinoma that took place in North Africa about 15 years ago. Well, inflammatory carcinoma is otherwise a pretty rare type of cancer, but there, because of environmental conditions, something was triggering it just to an alarming extent.
Well, we have men coming in with tender breasts, and they've been diagnosed, they're having hot flashes and night sweats, and I'm almost ready to send men for thermography. I think they need it just as much as the women at this point.
Well, one of the few advantages of being male is that you have about 1% the risk of breast cancer. Women don't get prostate problems, fortunately. That's a big enough problem for men, but
Yes.
Breast cancer in men does exist. It is rare, and it's usually something that's overlooked because it is so rare. It's almost impossible to do a mammogram on a man because you haven't got any type of tissue you can push between the plates. But with thermology, it's very simple.
So if you sent some 3 slides, which we'd like to show, and because we want people to see when women go in for a thermography, nothing touches them, and they put their hands in cold water, which you can explain why that is, and then you've got the thermography camera that takes a picture. So if we can show a few images, so tell us what this one is.
First off, you can see the figure form of frontal image of a woman. There is no color to the infrared, so the camera and the computer have color coded that around the temperature levels. Now, intuitively, the colors that you would think of as being cooler are representing lower levels of temperature. The warmer, the ones you would intuitively think of as being warmer are representing higher levels of temperature. So you see some of these track patterns. Those are blood vessels, and they're bringing warming blood from deeper in the tissue to the breast. This woman was scored as a TH1, which means of the lowest risk category. She doesn't have any of the thermal features that we associate with risk for breast cancer. I wish we saw a lot more of these.
So the next one.
Well, this woman has an asymmetry taking place. It's on our left, but that's over her. It's on her right breast.
Right.
In the upper portion of that breast, you can see the
See.
red and the yellow intruding onto the breast, which is representing an abnormal level of blood flow. And one of the key features identifying or characterizing breast cancer is its ability to demand and receive an exaggerated blood flow by the production of nitric oxide and the abnormal structure of new blood vessels. So this woman would be would be scored as a Th3, which is atypical, which is still not considered high risk, but certainly worthy of follow-up with other diagnostic modalities.
And then the third one?
Yes, this was an undiagnosed case, and you see the blue-white in the upper portion of this woman's, that's her left breast, and it's on our right.
Yeah.
This is representing an advanced breast cancer that we can follow through some of the tracks of the blood vessels. It indicates that the cancer has spread. This woman was actually undiagnosed at the time, so we were the first pickup on this disease, and it would take burning bush type miracle for this woman to have a good outcome.
Well, we keep the faith, right?
We do.
Well, the fortunate thing is that there's a lot that's happening in terms of treatment now. Treatment is becoming more individualized. There are choices beyond mastectomies, lumpectomies, and cytotoxic chemotherapy, but it all depends on where you go for that type of thing.
So I have some basic questions that I know that our viewers are wondering about. One is, does insurance cover thermography? And two, where do you go to get it done?
Insurance on it is spotty. Generally, insurance is not covering it because the national standards have not really been established for the reporting and analysis. There are many people who've gotten into the field largely because it is something unregulated, and they may have a hard time developing a practice otherwise. There are unqualified sources. It's really important to find a qualified source for somebody who's going to do the imaging as well as the analysis and reporting.
Yes.
Our website, thermoscan.com, has a locator in there that will direct you to responsible people in the different states.
And we have someone in this area that
Yes.
actually she was the thermographer for Dr. Terry Chappell for many years.
Okay, so we have
And
somebody
so,
locally.
yes, so
Yeah.
she travels around the area. We have her cards, her business cards, brochures.
Come into the store.
We've sent a lot of people
Come into
to
the
Betsy.
All right, my last question is, can thermography detect other cancers other than breast cancer?
Oh, absolutely.
Like
but,
throat cancer and stuff like that.
Well, we have it's absolutely amazing for skin cancers. It should be in every dermatologist's office. Here in Arizona, where we have laser-like sun and we get so many basal and melanomas, thermal imaging to be able to pick those up it should be part of routine screening. It's so much more definitive than looking for abnormal moles and then sending those off to pathology. You can basically, with thermal imaging, you can distinguish a mole as high risk of cancer very easily. We've picked up thyroid cancers quite readily. There are any number of other applications. We use it for studying components of blood flow through the major arteries supplying blood to the brain. Um, it has extensive applications in neurology. It's definitive of certain types of neurologic disorders. There are a number of legitimate applications for it beyond screening for breast disease.
Wow.
Again, our website is going to list some of that at thermoscan.com.
So I've been a cigar smoker for about 30 years.
Yep.
Okay. And
Stop.
I mean, thank God I haven't had any issues, but you don't inhale them. But it also increases your risk for throat cancer. So if I wanted to get a scan, should I just mention your name?
Sure. But
will I get a discount?
Well, actually, it would be pretty ineffective for esophageal cancer. There would be. It's a tough thing to diagnose. My first recommendation would be maybe you remember the late great Rush Limbaugh and how bombastic he was about his cigar use until he developed lung cancer. So my first bit of advice would be, please stop.
My wife's been talking to you, hasn't she?
I'm sorry. But an ear, nose, and throat could do an examination with a endoscope looking for unusual tissue changes. That would probably be the most effective means of screening for esophageal cancer, as best I know.
Well, and I go twice a year to the dermatologist, and they're always digging something out.
Sure,
so
but
maybe I should
right, and I hope the news has always been good, but now consider that the women who are getting abnormal mammograms, better than 85% of the time, those are coming back from pathology as benign. So that means that 85% of the time, an abnormal mammogram is coming up with the wrong answer.
And to go through all of that,
there's a particular level of stress that goes along with that, as well as all the expense to the medical network that's totally unnecessary, and that's because of an overdependence on mammography. When you start combining the different tools around the individual to use mammography when it's indicated, but then along with thermal imaging, in many cases, mammography right now is being combined with ultrasound. Ultrasound can be a good test, but it has certainly its limitations as well. It's also a structural test. Ultrasound is very tedious to get done. Its results are kind of nebulous. It really depends on how the test is done. It depends on who's analyzing the results, if it's going to be meaningful. Thermal imaging is much more objective. At Betatherm, you can make perfectly lovely images in Toledo, and we can analyze them here in Mesa, Arizona, and be completely objective about it, and quantitative and repetitive.
And that's, I just want to mention Betsy that does them in this area, and she's done these therms for many, many years. She sends them to Dr. Hoekstra. He does all the correct.
Right.
You do all the analysis on them. So
Correct.
Any woman that has them done here in our area with Betsy and Dr. Hoekstra, they're in the best hands you can be in.
Oh.
And actually, I didn't think of it. Betsy moves around Ohio. So she's in different offices around Ohio. And we could have put her phone number so people could call. But nonetheless, if you call the store, we can give you Betsy's phone number.
You said you had brochures.
At the store, yep.
Stop in the store, people.
We have, yes.
And if you go to our website, thermoscan.com, and look at the locator, you'll see Betsy's Operation Betatherm listed in there.
Good.
with contact information.
Man, fascinating. Thank you so much for joining us on the podcast.
Yeah,
we really appreciate it.
This
Well,
is a subject
my
that we
distinct
can
pleasure.
talk about a lot more, but I think we had a good start. You think it was a good start?
I think so too, but
Excellent.
I'd be pleased to come back and speak to you fine folk again and try to get the word out on this.
We would love that. We would love that. And I just want to say, I'm very grateful for your courage all these years. You've been a visionary. You're a leader. It takes a lot to stay the course with things that are not accepted by the established medical interests. So thank you for doing what you do. We're as women, we're very grateful. Thank you.
Thank you. I appreciate that.
And we'll talk very soon.
All right. I thank you and wish you a pleasant day.
Thank you.
Wow. That was good.
That was excellent.
That was really
Yeah,
good.
he's
Especially when he explained the images.
Yeah.
Yeah, I really enjoyed that. And we could have him on another time and we could talk about why isn't it accepted? What's in the way? And I think we know.
Well,
anyway.
What are you going to do?
But that was
terrific.
Yeah, that was really good
So
stuff.
we hope all of you enjoyed that interview because knowledge is power. And the more knowledge you have, the more empowered you become as an individual. So
because there's not a woman that isn't either already had a number of mammograms or is going to.
Right.
There are options. My wife dreads them every time.
Yeah.
And now we have new information to go with.
So very good.
So, all right, Claudia, last word as always.
Keep your heart open. Keep your mind open. There's a lot of amazing things that we have access to for our own health. And, you don't want to depend on all the stuff out there. You want to learn and you want to utilize it for your own self. So thank you for joining us. We very much appreciate it. Keep growing, keep thinking, keep the faith.